Thank you for joining us. You are a part of a powerful group who recognizes that Black women's health should be at the forefront of the national conversation. We are mothers, daughters, activists, entrepreneurs, entertainers, corporate warriors, and more, who help boost the economy and often drive the national conversation. For almost 40 years, the Black Women's Health Imperative has strived to amplify our voices, help enact policy that protects us, research our issues, create programs that enhance our lives, and produce events like this one to ensure we keep the conversation going about the issues that matter to us most. So, let's get started with our program.
Good afternoon. I'm Leslie Foster and really delighted to be your moderator this afternoon. And on behalf of the Black Women's Health Imperative and our partner, Healthy Women, I'd like to welcome you to another great episode of Reclaiming Your Wellness. Now, this is our campaign to really raise awareness of obesity as a chronic disease and to do this in a way that gets rid of bias, stigma, and shame, which is so very important. This is a national health crisis, obesity, and it's desperately in need of help and change at the federal level, and we are working diligently to see that change occur. We, of course, are commemorating February as National Heart Month and Black History Month. So we're looking at this connection between obesity and cardiovascular disease, also known as heart disease, which is a spectrum of conditions involving the heart and blood vessels. This, by the way, is the #1 cause of death in the United States. It kills more people than all forms of cancer and accidents combined. That's really an arresting thing. So the topic today, obesity and cardiovascular disease with spotlight on stroke, is going to provide some information that could help save you, your loved ones, your colleagues, and we invite you to share this with them if they aren't able to be with us right now. But before we dig in, I've got to get you to the facts because those are really important to understand as we dig in deeper into these issues. First on obesity, because over 100 million adults, adolescents, and children are living with obesity, and that includes 30% of Medicare beneficiaries, and the prevalence is highest among Black and Hispanic communities, and the numbers are staggering. Let me share them with you because nearly 50% of non-Hispanic Black adults and 45% of Hispanic adults are living with obesity. And then when we start to drill down even further and we talk about Black and Hispanic women, 80% of Black and Hispanic women are living with obesity or are overweight. And people living with obesity continue to face that social stigma that we're trying to eradicate. It's this widespread perception in our community that obesity is a lifestyle issue. But since 2013, we know the American Medical Association has recognized obesity as a chronic disease, a disease caused by a range of issues that could be biologic, genetic, it could be environmental, just like any other serious chronic disease. So we're working to change the language and the perception of living with obesity. Now, when we talk about cardiovascular disease, or we're going to call it CVD, we also know that Black Americans are 30% more likely to die from CVD than our white counterparts. And this statistic here is what gets me right here in the gut. Cardiovascular diseases kill one woman every 80 seconds. We're going to be together here for 60 minutes. Imagine how many women we will lose in that time. But the goal here is to keep that from happening. And that's why we want you to stay with us for this important conversation. According to the American Stroke Association, stroke kills more than 85,000 women each year. It's the third leading cause of death in women in this country, and it causes about twice as many deaths in women every year as breast cancer. Women experience 55,000 more cases of stroke annually than men, and women are also more likely than men to suffer a direct connection between stroke and dementia. Now, I know all of this is a lot of information. It may seem scary, but we have assembled an incredible panel of caring physicians and experts who are going to walk us through all of this step by step. So allow me to introduce them to you now. First, we have Dr. Tiffany Bell Washington, who is a diplomat, the American Board of Obesity Medicine, and a diplomat, the American Board of Lifestyle Medicine. Next, we have Dr. Akeem Allende. He's a board certified cardiac electrophysiologist. That's a big title. And co chair of the cardiology subsection of the National Medical Association. We have Dr. Yolandra Hancock, who is the founder and the CEO of Delta Health and Wellness Consulting. And to round out this stellar panel, we invite Dr. Rachel Bond to join us. She is the Women's Heart Health and Prevention Specialist, and she is a board certified attending cardiologist. So happy to have all of you with us this afternoon. We know this month in particular, it is a very busy time for all of you. So thank you for making some space for some courageous conversation. By the way, this conversation really is all about you, all of you who've joined us this afternoon. So if you've got pressing questions, we want to hear them. Place them in the chat. And once we get to the end of our conversation with the physicians, that'll be your chance to dig in. So Dr. Bell Washington, I want to start with you. And I think it's really important for us to walk everyone who's joined us today through this step by step, because when we talk about obesity and cardiovascular disease, those are two big tent issues that can come with a lot of information and it can be a little scary. So let's get everybody on the same page and talk about, in layman's terms, what is obesity? Why is it classified as a chronic disease? And why is that important?
Thank you for having me. I'm very excited to talk about this topic. I'll start by saying it was mentioned earlier, but in 2013, the American Medical Association decided that obesity was a disease. And this was a big deal for us because it made it so that people were less focused on this being a personal failing and something that our patients are doing wrong, something that we are doing wrong, and more that this was an actual disease that could be treated, should be recognized. It was a very important distinction. Now, that was 10 years ago. And so I have to be honest and say that I don't know that the unified opinion of obesity has changed that much, even in the medical community, unfortunately, or in the lay public. So that is unfortunate. And it tends to be something where people are blamed for their obesity. You mentioned stigma and bias, that happens quite a bit. But obesity is a highly prevalent, so 2 out of 3 people may have overweight or obesity disease. It's chronic, relapsing, meaning that someone can work really hard, they can lose weight, and their brain and their body will work very diligently to get them back up to the set point. So unfortunately, they may end up gaining this weight back. And the disease of obesity is essentially having too much fat accumulated on your body. And I'm not calling someone fat, I'm saying the actual fat molecule, it's too much building up in storage. And that obviously leads to a plethora of diseases, several cancers and heart diseases we're going to discuss today, difficulty with sleep apnea, those things. So it's very important that we focus on obesity as a disease, not just a cosmetic issue.
And for our friends who are just perhaps maybe joining us for the conversation today, I think it's important the words that we're using, because often we hear people say someone is obese, but we're really talking about personhood here and calling this what it is, which is living with obesity, which is a chronic disease. And so you're not going to hear anyone here call anyone obese, because what this is a chronic disease. And we're talking about people who are living with the chronic disease of obesity. Let's talk about, though, how the brain is involved with obesity and whether genetics may play a role.
Excellent question. Obesity is absolutely a brain disorder. And when people first hear that, they don't necessarily, 1, believe it, or 2, they're really shocked. But we shouldn't be too surprised because our brain controls everything we do. So it controls all of our bodily functions, from sleep, hunger, our stress, flight, fright, or freeze. Most people have heard of that, rest and digest. And it also controls our weight. And so because of that, there are some people who have set points that are just higher. And by set point, I mean, even if they eat very healthy, they eat fruits and vegetables, they exercise, their weight, because of their brain, is going to be on the higher end. And even if they were to diet or do these other things, they still may not lose weight easily. And then you have other people who can, they have a higher propensity to burn fat, burn calories, and they store less fat just in general. So that's very important, because you have, for instance, maybe seen people who are very thin or they appear fit. They seem like they can eat anything, but we don't know much about their habits, right? They may be eating healthy or they may not be eating healthy, but their bodies still are thin. Then you have people who may be on the have a larger body, and you may make assumptions about them that they're not eating healthy, they're not living right, and they may in fact be following all of the rules, that we put on people, but their bodies just are more prone to store body weight as fat. So that's something to keep in mind. And then in terms of genetics, I would say that it's a very genetic based disease, and the percentage goes up to about 80%. And what I try to tell people, which that's very shocking as well, if you see two tall parents, if the mom is 6 feet and the dad is 6'2", no one is surprised that they're going to have children that are pretty tall. The same thing goes for obesity, that if you have two parents who have obesity, they have the disease of obesity, they're living with that, they're working on that, and they have a child, that child by the time they turn 18 may have a higher propensity of having obesity, up to 80%. And I think that's often forgotten. And again, there's a lot of blame on the individual.
That's interesting information and important for us to know. I'd like to bring in Dr. Hancock now to build on what we've started to lay here, which is this understanding of what obesity is and how it impacts the body. And I think, Dr. Hancock, there is this belief amongst some people that it's just food, right? That it's just food that contributes to the disease of obesity. But we hear now so much about the social determinants of health, the things that impact our health and our body that have nothing to do with the food that we eat. Let's talk a little bit more about that and how that plays a role in the disease of obesity.
Absolutely. First, thank you to the Black Women's Health Imperative for having me, and to my beautiful soror for always showing up and facilitating these amazing conversations. It's really important to recognize, to your point, that obesity isn't simply a disease of overconsumption or lack of physical activity. The disease of obesity develops coming out of the social determinants of health, those factors where a person is born, grows, ages, learns, all of those components, where they live really is important. Examples include economic achievement, because economic achievement determines housing access. Housing access determines the neighborhood you're going to live in. The neighborhood you live in determines the choice in terms of food access, safe space for physical activity, etc. A perfect example is the District of Columbia. We often describe it as the tale of two cities. The District of Columbia is divided into 8 wards. Ward 3, as an example, is very affluent, predominantly white. Wards 7 and 8 are under-resourced and have the highest concentration of African-American residents. In Ward 3, there are 16 different grocery stores, one grocery store for every 9,000 residents. Between Ward 7 and 8 combined, there are 3 grocery stores, one grocery store for every 85,000 residents. And it isn't simply about quantity, but it's also quality. So if I go to a grocery store in Ward 8 and the prices are different, they're higher, the quality of the groceries are different. I often give an example. When I used to work in Southeast, I went to the grocery store where my families go because I wanted to understand the experience. Got home to Prince George's County, opened up the bag of cherries. Half the bag of cherries were bad. I had the capacity to get in my personal car, drive back to the grocery store, and advocate for myself. But a different circumstance would have negated my ability to be able to do that. And we have to think through, what is the lived experience of a family? Are they really going to risk spending money on something that they know is not going to be as equitable in terms of quality? Are they going to get on a bus with their kids and their grocery bags, go home, cook a meal that their child may not want to eat because they don't like it? Instead, there's this concentration of fast food establishments nearby that I know if I take my $10 and get food, my children are going to eat it. It saves me time, money, and frustration. And I get it, as a parent and a pediatrician, I understand that we try to make the best choices we can for our children. But if I live in an environment that makes it difficult for me to be able to do that, then how can we as healthcare professionals say, well, just eat healthier, just go out and exercise? And this goes from economic and educational achievement all the way down to policy decision making that also influences what resources our families have available to them in terms of either protecting against or facilitating the development of obesity.
Yeah, you just mentioned that, and we're hearing more about the political determinants of health. And so how is that different from the social determinants of health?
That is an excellent question. I'm so glad that you brought it up. We don't often talk about the political determinants of health in these conversations around obesity. And I have to give credit to David Dawes. He's the executive director of the Satcher Health Leadership Institute over at Morehouse. He actually just pushed a book out specifically talking about these political determinants of health. So if social determinants of health directly influence our choice, the political determinants of health directly influence the social determinants. So the policies and the politics around housing, healthcare, et cetera. I'll use housing as an example. So the Federal Housing Administration, federally and locally in places like the District of Columbia, literally codified racism in their housing policies, such that Black and brown communities, families were not able to access the same amount of capital to purchase homes. We know even in present day, the undervaluing of Black and brown properties. All of that influences whether or not I can afford to buy a house. It determines where I buy a house as a Black person in this country, and where I'm quote unquote allowed to buy a house directly then influences what my exposure is to all of those social determinants of health, right? So depending on what the housing policy is, that's going to impact my child's educational experience if I live in a concentrated area of poverty, simply based on how politics play out. In the way that Mr. Dawes describes it, he says it's the structural relationship between people, politics, resources, and power. How all of those come together to determine whether or not there will be equitable access to housing, education, etc. And when we really understand the power of politics, I always say there's health in all policies. Until we fully understand the power of politics and policy in the relationship of obesity, we're going to continue to butt our heads, because it also influences things like the coverage of medications, the coverage of care when a patient comes to see me, whether or not insurance is going to actually pay for a visit related to obesity. All of those are really housed under that umbrella of the political determinants of health.
And then if that's not enough, we can talk about how obesity, think about all of the things that you just mentioned that contributed to obesity. And so if you're living with obesity, that also spills into what happens with our cardiovascular health. And so I'd like to bring in now Dr. Bond to talk a bit more about this, because we're building up to understand a bit more about how all of this is interconnected. So we know more about what obesity is, what the causes of obesity can be. How are something like stroke and obesity and cardiovascular diseases all interconnected?
Yes, and I too just want to thank the Black Women's Health Imperative for the opportunity to talk today on such an important topic. One thing that I think was so profound in terms of your introduction was just sharing the statistics. And one thing that I hope everyone leaves today understanding is that although the statistics are bad, they are largely preventable. And one thing to understand is, what are those risk factors? So we talked a little bit about one of them being obesity. We know that obesity is in of itself a chronic medical condition, but one that could impact those other risk factors like high blood pressure, high cholesterol, diabetes, even inflammation, because cardiovascular disease is an inflammatory process. When we think about stroke in particular, and I use the term cardiovascular disease, stroke is umbrellaed under that term. Also included in that term is disease of the arteries of the heart, or disease in the arteries of all of our entire body. But specific to stroke, what is occurring when someone has a stroke is that blood vessels that normally transport oxygenated blood, which is a good amount of blood to the brain, either has a blockage or that vessel itself ruptures and bursts. And we know that, adding more statistics to this, one person has a stroke in the United States every 30 seconds, but also one person can actually die from a stroke every 3 minutes and 17 seconds. And understanding what the signs and symptoms of a stroke are, but also what your risk factors may be, can actually largely prevent that. One thing that's important to understand is that, just as Dr. Hancock mentioned, a lot of the social determinants of health and the lived experiences are what really causes the disproportionately high numbers of heart disease and stroke under that umbrella, cardiovascular disease, in the Black and brown community, because we know that it's the lived experiences of the people of color, but particularly Black women and women of color, that we're seeing these highest rates, including these high rates from both heart disease as well as stroke. So when it comes to stroke in particular, knowing those signs are also key. Very common signs and symptoms that you may see in the setting of a stroke includes a facial droop, possibly the inability to move a part of your upper extremity or lower extremity, where because you notice that there's weakness to it. You also may have impairment in your speech. But what is most important to understand is if you think you're having a stroke or you are having the signs and symptoms of a stroke, calling 911 immediately and getting to that emergency room immediately can actually be life-saving. We think about time, and we know that when it comes to cardiovascular disease for both stroke as well as heart attack, the sooner you get to the hospital, the better.
And that can literally mean the difference between a positive outcome and a tragic outcome. We'll drill down a bit more into the symptoms and some of the risk factors in just a bit. But I want to ask you, because we know stroke impacts the brain, right? And so is stroke considered a cardiovascular disease? Are you saying that that's also part of the cardiovascular disease ecosystem that you've been, devoted to all these years?
Absolutely. So as noted, any disease of any vessel in our body is considered cardiovascular disease. And stroke, just as heart attack can impact one's life, we do umbrella that under the term cardiovascular disease. So it's important to understand that this is such a largely preventable condition, but the only way for us to prevent it is to optimize many of those risk factors that can contribute to it. There are risk factors that we may not have control over, but the ones that we do, such as a history of being overweight or having obesity, a history of high blood pressure, a history of high cholesterol, and a history of diabetes, which tend to be manageable risk factors, tend to make cardiovascular disease, including stroke, under that term, largely preventable.
One of the other things that we have to talk about when we think about cardiovascular diseases is something that many of us have heard of, but may not fully understand what it is. And you may have heard of AFib, but we're going to talk about that a little bit more with Dr. Allende, who is a board certified cardiac electrophysiologist. That's a big title, and perhaps folks may not be quite as familiar with what that is. But Dr. Allende, as I invite you into the conversation right now, I'd love for you to talk a little bit more about what that is. And I understand that your role is around heart rhythm disorders. Dr. Allende, do we have you here with us? Looks like we may have lost him, so we'll come back to him and talk about that a bit more when we're able. Oh, there he is. There he is. Dr. Allende, can we talk a little bit more about what you do as an electrocardiac or as a cardiac electrophysiologist, what that role is, and how that connects to what we're learning about what AFib is. And I'll have you talk a bit more about that as well.
Thank you for having me, Leslie. And thank you to the Black Women Health Imperative for bringing lights to this. We need to remember that the intersection of being Black and women, that's the highest, that's group of people have the highest risk of heart disease and dying from heart disease in this country. And it's important that, we shine lights and discuss ways to reduce this risk. Specifically, you mentioned AFib, and, leading up to this, I'm happy that we're talking about the disease of obesity. AFib, atrial fibrillation, is an electrical disorder of the heart. In my role, I treat electrical disorders of the heart just like an electrician. Imagine an electrician working on a car or an equipment. So that's essentially what it is. So the heart is powered by its own electricity, and the electricity works like clockwork. There's a generator in the top of the heart, and there are cables that conduct the electricity through a substation to the bottom of the heart. So the top of the heart beats first, and then the substation slows the electricity and then lets the electricity go to the bottom. So top, bottom. So it goes tick, tock, tick, tock. Now, in AFib or atrial fibrillation, this is a disorganized rhythm of the heart, where the top part of the heart, the generator no longer generates electricity at a certain rate. Now you just have chaotic rhythm. Luckily, what's saving us is, so the atrium, the top part of the heart, is going around 400 beats per minute. That's how fast like the heartbeat of a mouse is. If your heart goes at 400 beats per minute, you will die. That's not compatible with life. Luckily, the substation does not allow all those beats to get to the bottom. So maybe somewhere around 100, 150 beats make it to the bottom. So the person has irregular heartbeat because those beats, some make it, some don't make it. So irregular heartbeat, and different people have different symptoms. 2/3 of people with AFib will have symptoms such as palpitations. You just feel your heart beating irregularly. I've heard somebody describe it as like a symphony. I've heard somebody say it's like, they're like horses are just running around in my chest. Some people
Wow.
just feel tired. You just feel like, and you hear this, you hear some, oh, I'm just old. No, that's the AFib. Some people complain of chest pain. Some people complain of shortness of breath. And when we talk about risk factors specifically for today, actually, before I get there, outside of obesity, which I'm going to get to in a second, age is the biggest risk factor for AFib. So your AFib, so I say AFib is more of a disease of Medicare age, meaning once you hit 60s and older, you're more likely to have AFib. And an 80-year-old has a higher risk than a 70-year-old, than a 60-year-old. So the older you get, the more likely you will have AFib. Now, because women live longer than men, more women have AFib. More women are living with AFib than men.
But it sounds like you can live with AFib if you know what it is and you know what the signs are and you seek out help and you seek out treatment, which gets me to this next condition, right? Because you've said because women live longer, they tend to have this condition more than men. But when we look at the whole population writ large, who tends to be the person who ends up with AFib outside of age?
So AFib itself, the reason, if we think about the reason we go into AFib, it's more about, like Dr. Bond was talking about risk factors of cardiovascular disease. Those risk factors also apply to the heart in terms of AFib, and this include outside of age things like obesity, things like high blood pressure. If you've had coronary artery disease where there's blockages in the arteries of the heart, smoking, sleep apnea, anything that puts certain pressures on the heart is likely to lead to changes in the heart where the heart enlarges, scar will form in the heart, and that person is more likely to have AFib. Now, when we talk about the type of people in general, so it's been shown that African Americans actually have a lower risk of developing AFib compared to white counterparts. But there's a catch. When African Americans get AFib, we're more likely to have stroke and heart failure. So the complications of AFib is twice as much. Yeah, so that's why if you look at the general population, there's the number of people that have AFib, it's less than African Americans, but when you look at, they are actually the sicker ones because the risk, AFib in general increases your risk of stroke 5 times, increases your risk of heart failure, reduces your quality of life, increases the risk of dementia, cognitive decline. And those are reasons why it's important that, these are controlled. And especially for African Americans, note that the risk is not the same. And, you have to pay attention to it. And this complications can actually be avoided.
So, Dr. Allende, you have talked in mass about how AFib and obesity are interrelated. I'm going to go back to Dr. Bell Washington and actually bring all of you on for this next part of our conversation where we'll talk a bit more about everything. But Dr. Bell Washington, we've heard each of you talk about how obesity impacts cardiovascular disease and cardiovascular health. So how do we address this? Let's talk about some of the innovations that are out there now to address obesity and hopefully stave off issues around cardiovascular health.
Excellent question. And so what I would say is that, as Dr. Bond mentioned, I believe it was Dr. Bond, it's great that there are treatments, there are ways to prevent obesity and then treat it if someone is already suffering from that. For every patient that comes in, we should be screening for obesity. So we may not go into detail, but they generally get some generalized BMI, which is not very accurate, but they will at least assess that, and you can check them for other complications. But then you do an obesity assessment, and then you get into the stage where you obviously suggest lifestyle changes. Those work, but they are not the solution for most people, although we all should be doing the healthy lifestyle things that we can do. And then we also offer medications. So there are several FDA-approved medications. I won't name them all, but they work in different ways. They may block the fat in your bowels. They may help your appetite be decreased. Some of them help with like brain mechanisms of cravings and hunger in that way. And then we have newer medications, GLP-1, that class, and GIP, which they basically address your hunger in your brain, your satiation, whether you're satisfied, whether you know to stop eating at that point. And that's how those medications work. I think you may ask me something about whether or not I can get coverage on those.
Well, yeah, I mean, the drugs are great if you can afford them, right? If you can actually access them. And we've seen a great deal of stories of late about people who wish that they had access to these drugs, but they are price prohibitive in a lot of ways. So how do you manage that as a physician who's trying to help someone living with obesity to have a longer life, to be able to thrive, and to know that this resource may be out there, but not within reach for your patients?
Yeah, that is a very tough situation to have, because we've been in this situation where for years all they said was just eat better and exercise and control your stress and you'll do fine. To have in our hand medications that we can use to help people, and then not be able to either, sure, I can write the prescription, but even if it were me, if I had to decide between, am I going to spend $1,000 a month for this medication for my weight, which I might look good, I might not worry so much about it, I'm not sick yet, or get my food or feed my kids, that kind of thing. It becomes a very difficult choice for patients, and even patients who are very, like, they have medical coverage, they are insured. A lot of times these medications are not covered on private insurance, and they're also not covered on Medicare and Medicaid. And Medicare sort of sets the stage. And so if we don't get the coverage there, it's unlikely that private insurances may all just jump on board as well. So that becomes a policy challenge that we have. And that policy, there's TROA, so Treat and Reduce Obesity Act, that we keep going to Congress for, and we're trying to get approval. And, even I've spoken at the White House to sort of explain why this is important and how we are limiting available medications that can prevent obesity, prevent a lot of times bariatric surgery, prevent heart issues, and prevent these deaths of the Black woman is a staple in the community, and it's hard to lose so many people knowing there are options there. So what I would say about that is there are treatments available. Some of them are affordable if you're willing to go with the older medications, which do work, but the newer, better medications that people are losing large percentages of their body weights, unfortunately, due to policies and insurance coverage, it's difficult to get our.
Sounds like what I'm hearing you say is that Medicare actually needs to provide that coverage, so
Yes.
that the other insurance companies will do that too. Dr. Hancock, I know you treat children as part of your healing gifts there. And just last month, the American Academy of Pediatrics changed their guidelines and even their recommendations for the first time in 15 years, actually acknowledging that obesity treatment is safe and effective for children and adolescents. And I'm wondering, is that progress?
It certainly is. It was long overdue. I was part of the review committee back in 2007 when the initial expert guidelines came out. So to see it being updated and then being inclusive of anti-obesity medications is refreshing. For those who have not gone through the board certification, like Dr. Bell Washington and I have, in becoming board certified obesity medicine specialist, this provides an excellent framework from which to be able to manage children dealing with obesity. Not only does it really address the multifactorial components of obesity, because even within our areas of expertise, we have colleagues who still believe that obesity is a hand-to-mouth disease. I've actually had colleagues say that to me. So the fact that the American Academy of Pediatrics, the nation's organization of pediatricians, has took a stand to say that, one, obesity is a disease that's multifactorial. Two, there are a lot of questions that need to be asked in a visit, not just about health habits, not just about nutrition and physical activity, but addressing, to the point that you raised earlier, the social determinants of health and what the neighborhood influence is, what the economic influences are, what the school environment is, things along those lines, to help us better understand how this child is navigating through this, what we call obesogenic environment. Not only that, it also outlines for us what the workup is. How do you manage a child dealing with obesity? Evaluating on physical exam some of the comorbidities that we sometimes see, the disease processes that happen along with obesity, like high blood pressure. In pediatrics, it isn't as simple as looking at the number. Physicians, PAs, and NPs need to pull out the National Heart Lung Blood Institute's chart to determine a child's blood pressure based on their age, their gender, and their height percentile. It requires a lot more time. And then, of course, the inclusion of anti-obesity medications as part of the management. And when it comes to managing obesity in the pediatric population, it's based on their BMI, which is the only tool we currently have until one of us thinks of something better. But it also determines what area do we focus on. Is it lifestyle that we focus on in terms of providing them with tips? And when patients come to see me, I don't focus on weight, I focus on health. So we talk about nutrition, physical activity, sedentary behavior, how long do they sit, how much screen time. We talk about stress, both in the home and outside of the home. We talk about right now how the impact of the pandemic has impacted children's health. We also make sure that we screen for depression and anxiety. When it comes to anti-obesity medications and how we address obesity, one of the things that I really wanted to mention was not just the coverage of the medications, which for children doesn't exist, right? Even metformin. I've been using metformin in practice for like 15 years. It's still not approved by the FDA as an anti-obesity medication. And so I have to go and do paperwork every single time I get ready to prescribe it. And even though the FDA has approved some of these other medications, insurance will not pay for it, or children have to develop comorbid conditions like diabetes in order to qualify. Not only that, the cost of care to do everything that these expert guidelines have listed out, it would take at least a 60-minute visit. We get paid a third of what we charge in the context of a visit. I have my own practice, so I can create a space for a 60-minute visit. But in a routine primary care situation, a setting, that's non-existent. And so for us to be able to provide the care that's reflected in these expert guidelines, it not only requires insurance companies to pay for these medications, it requires them to actually pay for the basic medical care. And that's something that we don't often talk about.
So it's really important to get a handle on whatever may be contributing to the disease of obesity, both in adults and in children, because those children become adults who may then soon end up in your office at some point, Dr. Bond, talking about these issues around heart health. And so I'm thinking about something you were talking about, risk factors and symptoms of something like a stroke. And so as we turn a bit more toward cardiovascular health, and when we think about women in particular, since women tend to be disproportionately impacted by this, let's talk about what these symptoms are. And I think it's important that you make this really clear because, listen, as Black women, and Dr. Allende knows this, right? We are really good at taking care of other people. We are really good at trying to take care of our kids. We are really good at trying to do all the things. And sometimes we miss the whispers that our body is trying to say something to us. So I want you to talk to us directly about the things that should arrest us, whether it seems little or not, because stroke is so serious.
Absolutely. And even beyond stroke, thinking about a heart attack as well, right? So I went through some of the more common symptoms of a stroke, which, just to reiterate, includes the acute onset of lack of ability to speak. So when you know that you're slurring your words, if you have weakness in your arm or your legs, or more importantly, if you possibly even have a feeling that you have a droop, like a facial droop, those are signs, the more typical signs of a stroke. And when we think about even a heart attack, the typical classic signs are in the movies where someone's clutching the center of their chest, and that chest pain, which sometimes could be described as an elephant sitting on their chest, may radiate down their arm, which begins to tingle. And although these symptoms actually do occur just as commonly in women as they do men, about a third of the time, women may have more subtle signs and symptoms of both a stroke as well as a heart attack. So fatigue, a very common thing that Black women may experience for all the reasons you mentioned, taking care of everyone, even hopefully themselves. Tiredness and fatigue that is not going away, even if you are sleeping the amount of hours which is recommended, which preferably should be 6 to 8. That could be an early sign that there's something going on from a cardiovascular perspective. Feeling a little winded or short of breath, or maybe feeling a little bit of indigestion in your stomach. These are things that would really implore you to act and actually see your physician or clinician to get checked to make sure that it's not anything going on with your heart, not anything going on with your brain, especially if you have any of the risk factors that we've already mentioned.
And it sounds like time is really of the essence here when
Yeah.
you're talking about the onset of those symptoms.
Absolutely. So for both the brain as well as the heart, the onset of those symptoms, the second you experience those symptoms and the second you think in your mind that you're having an acute cardiovascular event, calling 911, getting to the emergency room and seeking help, that could be the difference between having a bad outcome or having an excellent outcome.
Dr. Allende, I wonder if weight loss, because we're talking about this in the context of living with obesity, if we were able to reduce that, could we reduce then, say, the progression of AFib and then by extension stroke?
That's an excellent question. So AFib accounts for 15% of all strokes. And we know obesity is, we mentioned, it's one of the risk factors for AFib. In fact, there was a study published about 3 years ago that looked at people who had morbid obesity, where your BMI, so their BMI was above 40, and they underwent surgery, either gastric bypass surgery, gastric sleeve, or gastric banding, which are all different methods of surgery to try to reduce weight. And interestingly, those that underwent gastric bypass had 71% improvement in their AFib. Now that is proof that weight loss, I mean, we can't get better proof than that weight loss improves AFib. So weight loss reduces the risk of AFib. And for those that already live with AFib, weight loss can reduce the progression or even have the AFib regress. So it is important, of course, not everybody, I think gastric bypass is for certain, you have to qualify for it based on weight and some other factors, but weight loss at any set weight for anyone that has anyone that lives with obesity, you're likely to not only reduce AFib, your AFib risk and your AFib burden, but also reduce the risk of complications of AFib such as stroke and heart failure.
So this conversation has been so insightful, but it belongs to those who have gathered today to hear all of you. And I want to encourage you. I see questions in the chat, and we're going to get to those in just a second. But I want to encourage you to continue to put those questions that you have in the chat, and we're going to try to get through them as rapid fire as possible. For some of these questions, we're going to go back and talk about the obesity part of the conversation. And so let me start with you, Dr. Bell Washington, because we're hearing questions, and Dr. Allende just mentioned this, the bariatric gastric bypass surgery. What are your thoughts about that?
Excellent question. So I get that question a lot about not just the gastric bypass, which is a certain type of bariatric surgery, but just bariatric surgeries or procedures in general. And Dr. Allende mentioned that it's usually based upon BMI and weight. And, you typically have to have a BMI of around 35 to 40 with complications. So heart disease, high blood pressure, some issue. Or if you get to a BMI of 40, then you could qualify for it. What I typically tell people is that it's an excellent surgery. It does work. If you're going to have a gastric sleeve or if you're going to have a gastric bypass, those things work. Some people with the sleeve will have immediate regression, or they may cure their diabetes, and so it does have some hormonal changes that happen. But I often believe that if we could get better access to anti-obesity medications, so that those are the medications I mentioned earlier, and I don't call them weight loss medicines because that's not what we're trying to address. We're trying to address the health of the person, which they will lose some weight. But if we could get better access to these anti-obesity medications, we may find that fewer people need the bariatric surgery. And I always say, if you don't need to have a surgery, then obviously I would recommend that you don't get it, if there's another way. And the big issue there is that without access to the, if Medicare doesn't approve, if we don't get these laws changed and have better advocacy and better policies, then we're having people make it to the point of needing these surgeries when they could have been prevented before. And also Medicare, strange enough, does approve the gastric bypass and bariatric surgery. So you think to yourself, well, if they will approve something extreme as a surgery, which does work and it's been proven to work, then maybe we can get them to backtrack just a bit and approve these medications that would be more on the preventative side. It's already after the person has developed obesity, but it would prevent them from going further to have a surgery that could have undue side effects or unwanted side effects there.
Perfect.
If I could just jump in real quick.
Sure.
One, just in talking about bariatric surgery, one of the things that we also have to address is the stigma around referral to bariatric surgery, both within the patient population and within the clinical population. It's almost as if there's some sort of deserving. And studies have actually shown that Black and brown people are less likely to be referred for bariatric surgery, even though they meet and exceed the criteria. So we have to address the attitude, the beliefs in the clinical setting around bariatric surgery being a very viable tool in addressing obesity, but it's also a conversation with our families. Both as a pediatric obesity medicine specialist and in seeing adults, what I hear over and over again when I even just bring it up as an option, when I talk about the menu of options to treat obesity, the first thing I get is, oh, no, I'm not quitting. I don't need surgery. I'm gonna be able to do this. And it's, if you thought about any other health condition, if you had AFib and I offered you to see Dr. Allende to go in to have a procedure done, you wouldn't just say, no, I'm just going to see what my heart's going to do. You would actually go and get that procedure. So I think it's important for us to recognize that as well when we talk about that intervention.
Yeah, that's really important. I'm gonna move us a little bit faster through this a little bit, Dr. Washington, because I'm seeing a bunch of questions come through here. I hope that's okay. And we'll make sure that folks know how to get in touch with you all once this is over if they have additional questions. Dr. Bond, this one is for you. So there's an audience member who wants to know, is edema in a left foot an indication of heart issues? They say the right foot rarely swells.
Yeah, so what is edema, I think, is the first question that would be great to answer. So edema is usually swelling in some area of the body. And usually if the edema is in the foot, it could be from a series of things. I will say that when it comes to the heart or the cardiovascular system, we normally see asymmetry, meaning that if it does, or it usually is from a weakened heart muscle, that edema or that swelling may be both legs, both feet, both ankles. That being said, I do think that if anybody is experiencing edema outside of what's usual for you, it would be best that you speak to your healthcare professional, just because also sometimes medications may cause a little bit of swelling, common medicines that actually help with our blood pressure, as an example. So to answer your question, more commonly, when it's heart related, it usually is symmetric. However, it can very well be one ankle versus the other, but I do think it's important that if you have a new sign that is concerning for you, that you speak with your healthcare professional.
That's good information. Dr. Allende, one of our audience members says, can you have AFib without having any symptoms? Is that possible?
That's silent AFib. So 2/3 of people that live with AFib have symptoms, but as much as 1/3 do not have any symptoms. That's why it's important to get your regular health checkup. And these days, with the presence of smartwatches, I always encourage my patients to get a smartwatch, get something that gets some way to record your heart rhythm. These things have been, even though they're not medical grade, a lot they're not approved medical devices, but they do record medical grade EKGs that your healthcare provider can review.
Dr. Bell Washington and Dr. Hancock, a couple questions here. One is, how is obesity looked at in the United States versus other countries with better healthcare systems? I'll let one of you take that one, and then there's another one after that about intermittent fasting. And I'm assuming that's a question aligned with, does that have any impact on combating the disease of obesity or trying to move through that process? So the first question, how is obesity looked at in the United States versus other countries with better healthcare systems?
What I would say, I'll answer the first question. There's stigma. Stigma's universal, right? A lot across the globe is with obesity, it's seen as personal choice. The difference in the United States versus other countries really is policy related. We know that here in the United States, big food, big beverage influence our food policies. They actually sit on USDA committees. There is targeted marketing, particularly of people of color, where there are very few protections. Even the ingredients, the components of some of the foods that are available to us here in this country, you see significant differences in places like the European Union. And I would say that when you look at other countries, there are more protective policies in place. One, just in terms of coverage of care, having universal health care makes a huge difference. We don't have to worry about which health insurance covers what and how much they're going to reimburse for various services. That's not an issue in other countries. And in other countries, there is the celebration of a curvier body, right? And so there's also that balance between what is body acceptance and love of self in certain countries, and here in the United States, having a certain perception of what is acceptable in terms of beauty standards. We have that conversation to deal with as well. But when it comes to the clinical management of obesity, what I would say is that the United States is doing very well in terms of how we're addressing it from a clinical standpoint. We do have medication options. The challenge, as we've talked about before, is the lack of coverage, and that's where we have huge strides to make.
Dr. Bell Washington, intermittent fasting. You can't go into a grocery store without seeing entire magazine issues all devoted to intermittent fasting. Can that help with the disease of obesity?
Great question. I would say the jury is out depending on who you ask. So intermittent fasting, just for those who may not have heard, is essentially eating within a certain window of time. So you want to try to give your body, maybe 12 hours without eating, or you might go 8 hours overnight without eating, or 16, just the number varies. There's been research to show that ultimately it may not make a difference in the long run, but really there's no one diet that we recommend, for everyone. So I have patients who do very well with it, but what I find for them is that when they are eating in that window, they're choosing foods that are appropriate to eat in portions that are appropriate for their bodies, and then they're able to manage not eating, because if you don't eat for 16 hours and then you go to a local fast food joint and get 2 or 3 meals, then obviously that's not going to in the long run really mean much for weight loss or for health. And so I would say that Intermittent fasting may work for some people because they don't want breakfast. They go to bed, they're not hungry, and they can make it those 12 to 14 hours, 16 hours without an issue. So it can work, but it's not the end all be all for everyone. So you have to speak with your doctor and choose carefully.
And Dr. Bond, I'm going to give you the last word, because my question for you to kind of pull all this together is, this is Heart Health Month. Actually, I was going to ask a question, but someone else has a question in the audience, so I yield the floor to them. Would vertigo be a sign of cardiovascular disease? Do you want to take that one before we go?
Yeah, so vertigo meaning the room is spinning. Again, these are very subtle signs that, if not typical for yourself, especially if you have any of the risk factors that we brought up today, absolutely can be a sign that there's something going on. It could be a sign that warrants you to have further evaluation. So you know your body better than anyone else. If something is new, if something doesn't feel right, I think the best thing to do is go to your healthcare professional, discuss it with them, because at the end of the day, we could hopefully prevent this largely preventable condition of cardiovascular disease.
Before we go, rapid fire from each of you. And Dr. Allende, I'll start with you and we'll go around. The one thing that you can do to guard your heart.
I'll repeat what Dr. Bond said. You know yourself better than anyone. Self-check.
Dr. Bell Washington?
I'm going to go with journaling for stress relief and exercise. That's one. Let's put them together.
Dr. Hancock?
I'm coming from the perspective of a mother. Assess your children's stress. Cardiovascular disease can actually start as early as 2 years of age. American Heart Association released a study recently showing that 10% of children 3 to 5 dealing with obesity had elevated triglycerides and low HDL, the good cholesterol. So assess your baby's stress, figure out what's going on with them, and protect their hearts.
And lastly, Dr. Bond?
Yeah, so think about this as generational health. What we do impacts our children. So go to the doctor, make sure you're going at least once a year for your annual checkup. But when you're going, you come prepared, you have questions, you are asking the questions what your target should be when it comes to all of those numbers we addressed, because as we said, this is such a largely preventable condition.
Dr. Bond, Dr. Hancock, Dr. Bell Washington, Dr. Allende, thank you, thank you, thank you. I'm gonna give like a little heart to all of you, just to say thank you so very much for giving us a part of your hearts this afternoon. You can tell when someone cares, right? And you all are clearly caring professionals. And sometimes that makes all the difference. So thank you from the bottom of my heart, and all of the people who've had an opportunity to join us this afternoon, for sharing a part of yours and ways to make sure our hearts stay even healthier. So thank you so much for joining our webinar today. We hope that this has provided you with information that will help you, it will help your kids, your families, your friends, your colleagues, anyone that you know and love on this journey. This will be on YouTube. So if you missed anything or you want to share it with friends, we're going to make it shareable for you. We want everybody to benefit. And on behalf of the Black Women's Health Imperative and our partner, Healthy Women, and of course, our sponsor, Novo Nordisk, we want to thank you for being part of Reclaim Your Wellness. Please visit reclaimyourwellness.org and sign up to be notified of future events. We hope you have a wonderful day in this month of heart health and beyond.